Okay, it looks like we're all being recorded now, so we have to be careful for our um, comments for posterity. I'd like to welcome everybody to the board. Dr. Jane, is this your first board meeting? You're muted.
Yeah. Good afternoon, Dean Curran. So, yeah, no, it is my first board meeting after the orientation. I did attend the first orientation session
So,
at the DPH office downtown.
I'd like to welcome Dr. Jane. Of course, he's from Emory, where I am, but he is a very distinguished neonatologist and just now retiring as chairman of the Department of Pediatrics at Emory and the chief pediatric officer at Children's Healthcare. So welcome, Dr. Jane, to the board.
Thank you so much.
And welcome to everyone else. Mr. Walker, do you want to call the roll?
I certainly would like to. Thank you, Mr. Curran. We'll start with Dr. Curran, present.
Yeah, here.
Dr. Rodriguez,
Present.
Dr. Cheek,
Present.
Mr. Lang, Dr. Mercer,
Present.
Dr. White,
Present.
and Dr. Shin.
I apologize. I did not unmute myself before I said present.
Was this Dr. Shin?
This
Or-
Lang.
Yeah, okay, Mr. Lang. Okay, thank you. Okay, Mr. Chair, we have everybody except for one board member. I did not hear a present from Dr. Shin.
And Dr. Jane needs to be added to the list, of course, so he's also here.
Yes, Dr. Jane, I'm sorry about that. Dr. Jane is present.
Well, thank you very much. Do we have minutes from the last meeting that have been reviewed? I think I remember them.
Yes, they were sent out last week. I reviewed them and I responded appropriately in accepting them.
Are there any additions or do we have a motion for approval?
So moved.
Second.
Thank you. Thank you very much. The minutes are approved. Now we go to new business. Dr. Toomey.
Thank you very much. It's wonderful to see you all, and I really appreciate you being here this afternoon. We have had a busy couple of months since we last talked. Not only, and you may or may not be fully aware of the work that we were involved in with the hurricane response. And it just seemed like a perfect time at this meeting, later in the agenda, to be able to tell you about public health's role in this kind of emergency response. Hurricane response was devastating, particularly here in the South, and how that role is so mission critical, even though it may not be always visible to everyone in the public. And so before that, I am really looking forward to two other talks. Sherry Drenzik, Dr. Drenzik, our state epidemiologist, has some interesting updates about some of the outbreaks and new infections we've identified, which is, again, a mission critical role of public health in the community. And also, I would like to do a shout out even before Dr. Mercer or Dr. Cheek do, that you'll be hearing an update on CCMV. And I really credit you both. Hello. I credit you both with really putting that front and center and helping us move it forward. And we're really excited to hear the updates. So why don't we begin with epidemiology and Dr. Drenzik and follow up on the bugs that are around Georgia currently.
Thank you so much, Dr. Toomey. Good afternoon, members of the board. It's a pleasure to be with you again this afternoon. This is the time of year when many folks begin thinking about seasonal respiratory viruses such as flu, COVID, and RSV. So I thought we would start our update today by talking a little bit about where we are so far with our respiratory virus season and what we may be able to expect moving forward in the winter months, if we can predict that. So let's have the next slide, please. Yeah. So first of all, again, just as a foundation, when we're talking about respiratory viruses or really any emerging infectious disease, they are characterized by being ever-changing and unpredictable. So it is absolutely critical that we maintain robust and ongoing surveillance, including genomic surveillance or molecular surveillance, which will serve to inform all of our prevention and control recommendations. These can look different, from month to month and year to year, and sometimes even week to week. So far, now that we're in mid-November, what does our respiratory virus season look like so far? And we'll focus primarily on the big three, which are COVID, flu, and RSV. And what can we expect moving forward as well? So far, as a preview, we have been seeing a much more typical picture for the seasonality of these three viruses. There was a long sort of lingering effect from the COVID pandemic in the way these respiratory viruses circulated in the subsequent years that made them look a lot different. For example, for the last several years, we had early and high RSV activity in the summer, whereas normally this begins in the fall. And our flu season was also quite early, right after the pandemic as well. So it looks like now that we're a few years out, from the pandemic times and the epidemic of COVID, we are looking at a very, so far, kind of typically emerging pattern with these three viruses. But we can never really, hang our hat on that entirely. That's why we have to continue to do surveillance. Things can change pretty rapidly, but I'll show you a little bit about, what we're seeing so far. And I want to add in there, speaking about things that are not as typical, I want to talk a little bit about bird flu as well. There have been a few sort of unpredictable and changing events also discovered by epidemiologic study and surveillance that is sort of affecting what we look at as far as bird flu risk in people. And this again is primarily among farm workers. So we'll talk about that as well. So next slide, please. So when we're thinking about what our respiratory virus season might look like, well, what does CDC say? They have a whole, infrastructure of scientists that look at epidemic forecasting and mathematical modeling to be able to look at these three viruses. And we know that when they circulate together, they certainly can impact each other. And if they're all, sort of heading towards peaks at the same time, it can also impact our healthcare capacities. So will we have what they call a triple-demic of these three viruses again this year? Well, CDC predicts or forecasts so far that this year is likely to be, lower than, again, the previous 2 years. So where you see the red arrow on the slide, this is the current respiratory virus season. It is expected to be a little milder, a little kind of lower in magnitude and in scope, and probably a little more, sort of typical seasonality where they're not all three surging at the same time. So we need to continue the surveillance for these three to ensure that we have a good handle on that to see whether or not this bears out or not. Next slide, please. So let's take a look at how we do this. Look at where we are now. So we look at all three viruses together. So we call this our, pan-respiratory virus surveillance. And if you look at the yellow line on the graph, that combines all three together. And if you look at the far right side of the graph where the arrow is, you can see that we are, again, if you look at all three lines, we have COVID, flu in red, RSV in blue, and all three of them together in yellow. So we're starting to see just some slight increases, but you can see overall we're in very, very sort of low levels. And if you look at that graph and you look at those big peaks that were like a year ago, again, that was all that was driven by sort of flu primarily. And then when you look at the second peak, which was this past summer, that was driven by COVID. So that was when we had that big COVID surge in the summertime. And as you can see now, we really are at really low levels. So what is sort of bearing out for these three viruses is that, again, we usually have certainly, flu and RSV driving our winter spikes. We have COVID plays a role certainly in winter, but we have been traditionally having these summer bumps of COVID as well. So here we are, mid-November, just starting respiratory season, and we're really just starting to kick off this activity. So let's take a look at each of these three very briefly and see where we're at. So next slide, please. So here's COVID. So right now, our COVID activity in Georgia is really at record lows. It's as low as it ever has been after that summer peak that you can, and again, if you look at the far right of the slide, this measures COVID cases. What I wanted you to get an appreciation for, if you can see it, is that the pink line is really on top where we are right now. And that shows you that even though we're at really low levels of COVID cases, COVID hospitalizations, and COVID deaths, the majority of these, all three of them, are still occurring among those over the age of 65. So and this is not really all that unusual. We've certainly seen most of our severe outcomes among this age, but right now, out of all the of the very little COVID that is still circulating right now, it's primarily occurring among those over the age of 65. And we were talking about COVID subvariants. These variants change over time and new ones emerge. The newest one that's on the slate that originated in Europe and spread pretty quickly in Europe over the summer is called XEC. And it's a hybrid version. It's kind of like two COVID variants put together. They think that these kind of things happen when a person may be infected with two different COVID variants at the same time, and they kind of combine into one and then move ahead and spread from person to person. So XEC is emerging and now represents about 20% of our cases, COVID cases. The KP3 1.1 is still the predominant one, but I expect that the XEC will be kind of our winter variant this year. And even though whenever these new ones emerge, they seem to spread easier, there is no evidence that they are more severe infections. And again, the new COVID booster should indeed, and data has shown so far that it provides protection against this variant. So COVID is on the low end for now. This may change rapidly. We certainly usually see a post-holiday bump in COVID once individuals are often together indoors, but I'll give you that update after the holidays. Next slide, please. So what about flu? Flu is another one. Right now, we are seeing really low levels of flu in Georgia. It's just barely starting. If you look at the graph, and it's the red line, it's got the red triangles on it. We're really just at baseline levels of flu. We really haven't seen a lot of flu outbreaks. We have seen very few hospitalizations. And most of the flu cases that we've seen and that we've heard about that are flu outpatient visits have been among children. Initially, we saw among school-age children primarily when they kind of first went back to school in the fall. And again, even though these levels are very low, and now we're starting to see some flu among a little bit younger kids too. But if you look at the red line and you compare it to those other flu seasons, those are all kind of previous flu seasons. Take a look at the green one. The green one that you see, that was 22. And so that was 2 years ago. Look at how high our flu level was right at this time in October and November. So really much, much different. Even last year, which is the yellow line or the gold line, that was again also really high kind of early in November as well. So again, flu seems to kind of be, sort of back in its typical mode as well, where we're going to have a slow start in October and then a peak likely at the end of December, beginning of January, which is what we see in that blue line. That was 2021. These things are not in stone, they can change. But so far, when we're thinking about and we wonder, well, what does it matter? Kind of like when it starts and when it peaks, it makes a lot of difference in how we can recommend, prevention measures about flu vaccine. And it also helps us to be able to prepare for supporting our healthcare partners for healthcare capacities. So far in Georgia for flu, again, we've seen mostly all flu A, not any flu B yet. It's been kind of a 50-50 mix of H3N2 and H1N1, still so early. And nationally, this picture looks exactly the same. So far, we're looking at, again, low flu activity, both in Georgia and also across the country. Next slide, please. And so number 3 on the virus list is RSV. And again, we had some really unique RSV seasons in the last 2 years. They started really early. They started in August and they peaked in September. And then they began to decrease in October. And October is really the time of year when RSV activity begins traditionally. It begins to increase and then and continue over the winter months. So as we were really concerned about RSV primarily for infants, primarily those under 12 months of age, can really be very serious infections or even deadly in this group. So we keep track of RSV by looking at the percent of PCR RSV tests that are positive. And what we've been seeing over the last 4 weeks really is a pretty traditional beginning to RSV season as well. We saw no activity this past summer, and we're starting to see increases, kind of bumping up throughout October. So as of last week, we were up to about 16% positive RSV tests. So it's beginning to ramp up. So we should be seeing, again, like usually RSV season peaks. When you look at the percent positivity, it's usually in the 20-ish%. So we're moving ahead. And again, it also helps us to be able to think about prevention strategies that are appropriate and recommended for RSV as well. The national picture is also similar, just like it looks right here in Georgia. Again, nobody had these really early RSV seasons. It looks pretty traditional. Next slide, please. And if we look at RSV hospitalizations in Georgia, again, the population at greatest risk, again, was these infants that were 12 months of age or younger. And if you look at where the black circle is on the right, we're starting to see some increases in hospitalizations, but nowhere near where we were a year ago. If you look at the left-hand side of the slide with the other blue circle, those were the hospitalizations at this time of year, exactly this time of year in 2023. And it's about 60% less this year. So again, we have a milder season so far, but perhaps we're just slower. We're behind. Maybe we'll be getting these larger peaks of hospitalizations as the winter months continue. Next slide, please. So those were all kind of traditional, the 3 RSV, COVID, and flu surveillance updates. But something unpredictable has already happened this respiratory season. And this one was unusual, and this one we didn't expect. It's not a virus, but so far this season's unpredictable event has been a large surge in Mycoplasma pneumonia in children. It's a bacterial organism, and it usually infects older kids. But since the summer months, we've been seeing, not only here in Georgia, but nationally, large spikes in Mycoplasma pneumonia infections in children that were young, like 2 to 4, or even younger than that. Sometimes this infection is called walking pneumonia because it's relatively mild. And again, the symptoms, can linger, but the illness is not very severe. And sometimes kids can end up going back to daycare or back to school, and it remains infectious for pretty long periods of time, even weeks. So they can end up spreading in this way and lingering. This walking pneumonia due to Mycoplasma is usually characterized primarily by a fever to begin with, upper respiratory symptoms, but a lingering cough. The cough can last for weeks. This particular infection is not what we call notifiable by law in Georgia. So again, sometimes it's not tested for, sometimes it's a clinical diagnosis even. But again, we don't have exact, sort of reports of the exact numbers, but we have heard from many healthcare partners and pediatricians that they have seen more Mycoplasma pneumonia in young kids than they really had ever seen before. So these children are not usually hospitalized or severely ill, but it can represent, a chance to spread to others. So we just want to be sure to remind parents, to remind children, it's not like there's a vaccine for this, like we have for flu or for COVID, and it is treatable with antibiotics, but if appropriate. But again, to remind parents about, sort of respiratory etiquette, staying home when sick. Next slide, please. And our last slide, one more unpredictable thing. And again, this one is a virus, but it's a bird flu virus, not our human seasonal flu. We had something unpredictable happen. As you know, bird flu has been spreading again among dairy cattle and also poultry farms for a long time, but this year primarily among dairy cattle. We had this huge outbreak of bird flu among dairy herds. Nearly 500 herds have been affected in 15 states. We have not had any in Georgia. And there have been actually 46 people who have worked on these farms that also acquired bird flu infections. And that is always a concern because an animal virus in a human represents a risk of change, of evolution, of acquiring characteristics that can spread from person to person and really may even generate a novel flu virus resulting in a pandemic. So anytime there's animal flu that gets into people, there's high concern. So this has been going on and has been sort of percolating along all year long. But what became unpredictable this last week was that CDC did a study of dairy farm workers and in 2 affected states and looked at even if they did not have symptoms of respiratory virus infection or flu, they remembered no symptoms at all. They, by serology, showed evidence of actually having H5N1 infections. So what that indicates is that they could, again, because of the close contact and higher risk exposures they have with dairy cattle or with poultry, they could even acquire infections that, did not really show severe symptoms or even any symptoms at all. And so what that represents is that if there's a flu virus, again, in a human, and they don't really recognize it, they're not tested, they're not treated, they're not isolated, it could represent a chance for the virus to change and then spread to other people. So that's the unpredictable event of this week and kind of concern. And for us in Georgia, we are not dealing with bird flu at all, and hopefully we will not have to. We have great plans in place in case we ever come across bird flu and in our dairy herds or in our poultry. But again, CDC this week is saying like, oh, well, since this happened, maybe we really should change the guidance slightly so that farm workers that have close contact with these infected animals should be either tested or treated if they have high-risk exposures, even if they don't have any symptoms. So more to come about that, but again, just to highlight how things can change pretty rapidly, even and as we learn more, and how the epidemiology helps drive our recommendations for prevention here. And my last slide, which is the next one, is really, in the bottom line, no matter the forecasts, no matter whether we're having a traditional respiratory virus season or an unpredictable one, respiratory illness has a tremendous impact on populations and healthcare capacities, but they are preventable. Ranging from something like mycoplasma or other respiratory hygiene across the board, stay home when you're sick, COVID boosters as recommended. And this year, what's new is that CDC says that seniors should actually get 2 booster doses of COVID vaccine 6 months apart. RSV, biologics and vaccines as indicated, and influenza vaccine for everyone over 6 months of age. So these things can change from day to day, from week to week, from month to month, and we can be assured that our surveillance mechanisms are in place, including genomic surveillance, that we can learn more and make critical decisions for prevention and control as we move forward in the respiratory virus season. Thanks so much for your attention. I appreciate it.
Thanks a lot, Dr. Drenzik. Do we have any comments or questions for Dr. Drenzik? I have one, Sherry. What are the isolation recommendations for somebody with mycoplasma pneumonia?
So it is similar to some of the other respiratory, and other, and conditions that if the child has fever is gone for more than 24 hours without the use of fever reducers and symptoms are resolving, they can go back to school. So it's not like keep the kids out of school for weeks on end, but similar to like if they don't have a fever, and try to practice the adjunct respiratory etiquette measures, about coughing and into your sleeve and that kind of thing.
So that's even though the symptoms are milder and the fever is transient, but the ability to isolate the organism is longer. Yes,
they can be. The duration of infectiousness can extend. In some cases extend. So primarily through, cough is one of the primary drivers. So we want to make sure that again we address some cough prevention measures as much as possible in these settings.
Okay, well, thank you. Next on the agenda.
Dr. Karen, can I ask a quick question?
Sure.
So, Sherry, does the onset of winter or the intensity of cold temperatures as they arrive have a temporal correlation with the spikes in these viral infections historically?
Sometimes we see this, although like you say, you saw several of these seasons can all look a little different. Very often, flu viruses can definitely be impacted by temperature. However, what we really see on a functional or practical level, and this is with COVID as well, it's usually about close gathering. So it's really like, so in the summertime, for example, we usually see our COVID spikes when it gets really hot and people start going indoors in the air conditioning together. And then we see flu spikes post holidays when people are gathered together also indoors. So sometimes it's a matter of sort of the indoor and less air movement rather than even just the outside ambient temperatures, but that can affect it as well.
Thank you.
Dr. Drenzik, next.
Hi, everybody. My name is Melanie Morris. I am the Child Health Deputy Director and the Director of Screening and Referrals. And thank you to Commissioner Toomey and the committee members for having me here to share some exciting updates on congenital cytomegalovirus. Next slide, please. So effective last month, so October the 10th of 2024, under Georgia Code Section 31-5-1, birthing facilities are now required to conduct CCMV testing on all infants who fail their final newborn hearing screening before discharge and before 21 days of age, whichever one comes earlier. Next slide, please. This is very small for me. I'm sitting too far away and it's probably small for you too. But what you really need to see from this is the timeline, and our timeline has a new addition in the red circle. So this all really started from some work in 2018, which I believe was from Dr. Mercer and Dr. Cheek, who approached the Georgia Academy of Pediatrics to have DPH consider adding CCMV to universal screening panel. A variety of events happened kind of throughout there, but ultimately the decision by our Newborn Screening Genetics Advisory Committee, the CCMV working group, they ultimately decided they would not want to recommend universal screening, primarily due to the specimen source, which is blood. So the sensitivity of the blood specimen is not quite as high as what we would like to see. And so in September of 2023, this working group, they were still chugging along. They made the recommendation to DPH for us to consider amending our hearing rules and regs to include the requirement of hearing targeted CCMV testing. So in October of last month, those amendments were adopted. Next slide, please. So I'll give you just a couple slides of the overview of those adopted amendments. But if the baby doesn't pass the initial or the final inpatient newborn hearing screening test, then the hospital or the birthing facility is required to conduct CCMV testing before they leave the hospital or before 21 days of age. And in here, so most hospitals will repeat the newborn hearing screening one time. But some hospitals may repeat it so that they can do it up to 2 times while the baby is inpatient. But some hospitals may just do it the one time. So we're kind of leaving that up to the hospital, but ultimately they have to get the CMV testing done before the baby leaves the hospital if they failed their final newborn hearing screening. And similarly to the way the rules and regs were already written around hearing screening is if a baby is transferred to another facility before that initial facility completed the hearing screening test, then that second or transfer facility must complete the newborn hearing screening test as well as the CCMV test. Next slide. Now, the results of the CMV test are required to be included in the baby's clinical record. So no matter what the results are, whether they're positive, negative, inconclusive, and importantly, the status of the CCMV test is required to be provided to the patient's healthcare provider on record and the parent or legal guardian. And this is really important because a lot of cases, the baby will receive the test, so the specimen will be collected, and then they'll be discharged before the results are obtained. And so we want that next kind of the medical home to understand where are they in the process. And so hospitals are required to let them know, we've completed the specimen or we've completed the test, we're waiting on the results, or we missed this and you need to do it. And then ultimately, if there is an abnormal result, so if the baby tests positive for CCMV, then the provider administering the test is required to notify DPH. It is now CCMV is now a notifiable condition. We've done a lot of great work with our epidemiology partners and that went into effect in October as well. And this is very important because once we become notified, then our follow-up provider informs the baby's medical home, as well as the parent and legal guardian. Next slide. So just some clarifying points. We always get these questions. It's not universal, so we're not doing a universal screening protocol. We're not screening every baby born in Georgia. We are only recommending that we're requiring that hospitals screen all babies who fail that final newborn hearing screening. So it's a hearing targeted screening protocol. It's not a legislative mandate. It went through our rules and regulations, adopted amendment process. And then one that we get this question routinely is that these specimens are not sent to our state lab. They're not sent to Georgia Public Health Laboratory. This is a point of care test where the birthing facilities must coordinate their own lab testing. And the good news is every large lab does this testing. So facilities are typically just using that same lab that they use for other specimens. And then the results are not reported on the blood spot card. The birthing facilities must notify DPH separately. Next slide, please. So on the right-hand side, just kind of a reminder why this is so time sensitive, but this CCMV screening, the right hand on the red, CCMV screening must occur prior to 21 days of life. Because if we test beyond 21 days, we don't know if it was acquired after delivery or if it was congenital. We are only concerned with congenital CMV. When CMV is acquired postnatally, it's not typically a big deal. It's like the common cold, but where it becomes problematic in many cases is when it is transferred to the fetus in utero. And then we are doing a hearing targeted screening, like I mentioned before. And then we are, in our policy and procedure manual, we are not recommending using dried blood spot. We're not recommending using blood at all, largely because the viral load in blood is much lower than in saliva and urine. And so if you test positive or if you test negative via blood, you really can't rule it out and you would have to do additional testing because it's not as sensitive as saliva or urine. If you test positive via blood, then we've ruled it in. But the recommendations that we've put out are to use saliva or urine. Saliva is a screening mechanism. So if a baby does test positive via saliva, they do have to receive the urine confirmatory or diagnostic test. But saliva is a lot easier to collect. So most hospitals, and what the CDC typically recommends, is that they use saliva as that first tier screening method, collect the saliva. If the baby tests positive, then we move on to urine prior to that 21-day age mark. With saliva, we have some protocols where there is some risk of contamination with breast milk, but we have ways to avoid that by instructing hospitals to wait an hour or two after feeding via breast. And then urine is our confirmatory, so it also has a high sensitivity, or it is highly sensitive, and it doesn't require additional testing. So that's kind of our confirmatory. We are working with pediatricians to kind of work through some challenges that they're experiencing with it's just not a typical specimen that they collect on infants in the outpatient setting. So we're really kind of listening to providers and trying to provide kind of support and resources to help them follow these protocols. Next slide, please. So I mentioned this before, but it is a notifiable condition now. So all infants who are 21 days of age or younger, the provider who completed the test must notify DPH if they test positive. Of course, this doesn't have to be physically the person who is taking that swab. This can be delegated to other staff within the facility. Next slide. So why is this so important to report to us? A few different reasons, but the main one being we have an entire follow-up program for babies that test positive. So any baby that tests positive for CCMV, we are informed at DPH. And then we have actually expanded our contract with our newborn screening follow-up provider, our largest one, Emory, to include follow-up on congenital CMV. And so DPH becomes informed. We immediately let Emory know. They inform the medical provider on record that their patient tested positive. They provide the next steps. They tell them which referrals they need to make. They even explain like how to communicate this to a parent. And then they provide the family with some educational resources as well. So that's kind of the main reason. That's why we're doing this. We want this to be a successful screening program by having this follow-up. But also it's a notifiable condition requirement. So that's why they should also report it. And then it's required via our rules and regs. But I mentioned the testing is very time sensitive. So it has to happen within that 21-day age range. But follow-up testing or follow-up procedures are also really time sensitive. So for infants who are going to receive antivirals for this, they typically provide those within the first 30 days, maybe 6 weeks of life. So we really are working on a kind of a short time frame. Next slide. So in addition to kind of rolling this out, we wanted to make sure that everybody was educated about this and that this wouldn't be a surprise to anybody. Our communications division has been incredible and has helped build out a bunch of educational materials that we've shared at a variety of different conferences, audiologists, OBGYNs, pediatricians, family physicians, and then we have provided quite a few presentations as well as partnered with Georgia Academy of Pediatrics to provide 2 different webinars. So we had one webinar provided by an otolaryngologist, and then we had another webinar just presented in September by an infectious disease physician in Augusta. And then our newborn screening program, we are now doing office hours once a month. And so it's basically a time for our program to kind of share best practice around newborn screening related topics. So last month I did present on CCMV and was able to share kind of the overview and the highlights of our policy and procedures. Next slide. So if you are interested in just seeing what all we've developed, or if you want to share this with any of your colleagues, that QR code that's on this page takes you to the link that's also listed there. But we've developed kind of the CCMV implementation toolkit for medical providers. Our goal is to basically provide all the resources and answer all the questions that providers may have when rolling this out. So it includes our policy and procedure manual, which we are routinely updating as we get more and more questions. Our protocols, we worked with a group of audiologists to develop our audiovestibular monitoring protocol because many of these babies who test positive for CCMV are going to be at a higher risk of progressive hearing and vestibular dysfunction. So we actually recommend monitoring them till they're 10. So 10 years of age, which is a long time to monitor, as well as just some other case report forms. Next slide. And a huge thanks. This is a large group of task force members. We had a lot of interest in joining our CCMV task force. And all of these individuals contributed to the resources that we created, including that policy and procedure manual. So we had infectious disease physicians, neonatologists, microbiologists, otolaryngologists, the list kind of goes on, audiologists. So we had a great group of individuals that have volunteered their time and really given us the information that we can share with our community partners. Next slide, please. And that is an end to my presentation.
Thanks, Melanie. It's very, very thorough. Are there any comments, particularly first from Drs. Cheek or Mercer? Dr. Cheek.
Okay, I've got my mute off. First, thank you for a great presentation. I think y'all obviously have known you've been working very hard on this for a very long time. Have there been any positives?
Yes, I'm glad you asked that. I didn't want to make a slide because it was going to have to get updated like this morning. We have 8 positive cases that have been reported since October the 10th. So far, none of those cases, like we've been within that 21-day mark. We haven't like missed that mark yet, which is really great. And yeah, I mean, honestly, I was kind of surprised. I didn't really think we would get that many so quickly, but yes, we've had 8 cases.
And I'm sure then in the future, you'll give us an update of the follow-up of, you know, what happened with those 8 cases and the others that will come forward.
Absolutely. Yes, of course. Yeah, that's where things are going to get, you know, that's why we do this. So that'll be an exciting thing to present on for sure.
And Dr. Cheek, this is Kathleen. I just wanted to say one of the reasons I thought it was so important for Melanie to present. I also have Diane Durrance here as well as Kimberly Ross. Kimberly, as you know, is head of child health. Is that I think this illustrates the importance of the feedback from the board to help guide our priorities and actually help facilitate some of the barriers we may encounter, because this to me is such a success story. And I wasn't aware of the newly found cases. So that's just even stronger evidence about how important this is.
And I will say, I don't think we would have had those positive cases had it not been for our epidemiology team and our work to make this a notifiable condition. So just huge shout out to them. So they've been incredible and have helped me learn the ways of epidemiology and how to make this happen.
Well, thanks to all for your hard work, and it's going to pay off, and some child is going to get to hear when they wouldn't otherwise. So definitely worth every moment of effort you put into it. So thank you very much. Thanks to your team.
Well, thanks to Dr. Mercer and Dr. Cheek for pushing this and guiding it. And Melanie, this is terrific. You're going to enjoy your introduction to epidemiology. It's a lifelong endeavor.
Melanie, can I say this is Dr. Mercer? I think this is remarkable, and 8 cases is just, I mean, that's profound, really. 8 cases in 1 month. I really like that factor that it's coming back to the Board of Health to then coordinate and be sure that the child is then placed into the screening that is required after a positive. I like that link, not leaving it up to the primary provider necessarily. So I think that was a very good link, and it gives us an opportunity to, of course, compile the data. And I like the fact that it's going to one institution at Emory. Can I ask one about payment there? If there's been any barriers with those 8 children in payment, do we need to be thinking about that? This is just a very technical question. When you talk about the difficulty of collecting urine, what now is considered the volume of urine necessary to run the test?
Yes, so good questions. So in regards to payment, I haven't heard of any concerns, but it's still very early, and I'm curious if they will come up, and they probably will. Before this rules and regs went into effect, we did meet with the Department of Community Health, and the codes are covered by Medicaid. But I know there are so many different nuances with billing that we'll if we get informed of it, then we'll definitely see what we can do to kind of enact on that. as in regards to the specimen, so it kind of depends on the lab, but typically it's like 1 ml of urine. The challenge that we have heard is mostly with little girls, it's a little bit harder to catch it, but we're recommending the use of a sterile bag. So we are no catheterization should be needed. And then some people used to use like a cotton ball method where they would put cotton balls in the diaper and collect it there. But the sensitivity is not very good with that. So we're not recommending that. So right now it's really just the sterile bag collection. And I think also pediatricians, don't typically have, or what I've been told, they don't typically have urine bags on hand for infants in their offices. And then just like it takes a while to have a baby urinate. So I've reached out to other states and figured out like, what are y'all recommending? Some of them are like getting the baby, kind of get the bag on and then send them home to have them urinate, and they're at home and not just sitting in the doctor's office. Also recommending if the baby is coming into the pediatrician's office for this test, don't have them sit in the waiting room, like go ahead and bag them and then go see the doctor after that. But yeah, we do have a nurse practitioner on staff who her topic and project right now is to investigate how we can support pediatricians in that collection. So,
well, thank you. This is an excellent report, excellent success.
Thank you.
Thanks, Melanie. Just let me ask you a couple questions for the non-pediatricians here. Two questions basically. One is on the incidence, and the question is, what proportion of newborns have hearing problems that would result in testing? And then the treatment question is, when is ganciclovir or one of the antivirals recommended, and is there a limit to how many days after birth it can be given? And then what is the efficacy in reducing hearing loss if you give ganciclovir?
Very good questions. All right, I'll tackle the first one first. So it's a little bit nuanced, but in Georgia, we have about 5,500 babies fail their newborn hearing screening before leaving the hospital. Not all of those children are going to have hearing loss. We expect closer to like 350-ish. So there is kind of this higher refer rate that comes with testing infants' hearing, which we realize, then we're going to be testing more kids for CCMV who end up not having hearing loss. But the other side of it is we know these families are not necessarily going to come back in time for that follow-up testing to confirm the hearing loss by 21 days of age. So if we had a longer time window, I think we would probably all agree it would be okay to wait until we have confirmed. But our loss to follow-up from newborn hearing screening is too high to kind of risk that. And then I can speak a little bit to the antivirals. It's not totally my area of expertise, but in the US, it is only FDA approved for symptomatic cases. And interestingly, they don't consider hearing loss to be a symptomatic case. So if they just have hearing loss and nothing else, then it is asymptomatic. But many infectious disease physicians in Georgia use joint or shared decision-making with the family. So the family in many cases would be offered antivirals with quote unquote just hearing loss. And as far as the efficacy of it, there's a big study that is currently, it's still underway, and we don't have the results yet, but what they're looking at is the efficacy and like how does it impact hearing, or how does it decrease the impact of the virus on the hearing organ. And I don't have that answer yet, but hopefully it'll come out. It's called the VAL-EAR study. So.
Thank you.
That's a national and an international study that's going on with UAB being the primary. And many years ago, the cutoff was 6 weeks. It might have changed.
Oh, yes. Thank you, Dr. Mercer. Yeah, I think one of your other questions was like the time of it. So yeah, by 6 weeks, they typically won't After 6 weeks, they will not start antivirals.
Well, thanks again, Melanie, and thanks again, Dr. Mercer and Cheek. Next.
Now what we've all been waiting for, this was probably one of the toughest responses I have ever, I'm not gonna say I participated in. I was here in Atlanta watching it, and every day there was some new development. So let me turn it over at this point to Dr. Rustin to introduce the other speaker in this area.
Yes, thank you, Dr. Toomey. And as mentioned, it has been an extremely busy season. We have been responding to hurricanes since August, September, and October. I think there was almost 60 days of response overall to these various hurricanes. What we want to do today is highlight the work of public health as it relates to responding to these various storms. Sometimes this is somewhat of an overlooked function of public health, but a critically important function that impacts multiple disciplines within our public health areas. Probably the take-home message before I introduce Leah is that with all these storms and with all the predictions that are out there, these storms are very unpredictable, as we saw with Hurricane Helene as an example, which was supposed to impact the west side of the state and actually cause more impacts in Metro Atlanta, but it actually impacted the east side of the state. And with that, I'm going to introduce Leah Hofhacker. She serves as our Director of Emergency Preparedness and is responsible for coordinating our public health activities during these types of responses. And so I'll turn it over to you, Leah.
Thank you, Dr. Rustin. Good afternoon. So today, as Dr. Rustin mentioned, I'm going to go through what our season has looked like and kind of what our structure is as public health, what our responsibility to the state is, and then kind of get in a little bit of what that meant during the season. Next slide, please. So hurricane season is June 1st to November 30th. As Dr. Drensick mentioned, we're moving into respiratory season, but that means we're moving out of hurricane season. We have a couple of weeks left, and we're all continuing, particularly because of this summer, still keeping a very close eye on the forecast. So just fingers crossed that we can make it the next 2 weeks. Extreme surface temperatures continue to be an issue. We've been getting reports every single summer that this is going to be an even more eventful season and a more eventful season. And I would venture to guess that next year will be the same result. We got out, even though we did respond so much this season, we actually got very lucky for a little while, very active in the Atlantic, but luckily no coastal hits, surprisingly enough, direct coastal hits. So Department of Public Health is responsible for serving as emergency support function 8. So underneath the National Incident Management System, we have emergency support functions. This works at the federal, state, and local levels, which DPH, Department of Public Health, serves on the state, district, and local county level as public health and medical services at all levels of emergency management. And I'll get into a little bit of a detail what that means on each of our levels in a moment. But in general, across the board, on all levels for us, that includes general shelter supporting, which I'll get a little bit more into. And as Dr. Rustin mentioned, that means it impacts a lot of our programs. For example, that includes nursing, epi, and environmental health, and it can include some of our other partners depending on the needs. Medical Transportation Office of EMS is underneath the Department of Public Health, so that is our medical services side. So we do healthcare evacuation support, transport support is needed. They'll support long-term care support transfers if they need to do that, decompression, general 911 support, lots of things. EMS is very busy during hurricane season. And then healthcare facility support. So my counterpart, Katie McKnight, is the Healthcare Preparedness Program Director. She serves as kind of, we refer to ourselves as two sides of that coin. I am public health, she is medical services. And together we are ESF 8. So they really work on making sure they coordinate with our 14 healthcare coalitions across the state, supporting those long-term care facilities, hospitals, dialysis centers, all of those healthcare facilities that are impacted by hurricane season. Next slides, please. So at the state level, so if you call the federal government the 30,000 foot level, the state would probably be the 10,000 foot level. So we do serve as we are the leads for public health medical services and report to the State Operations Center, and when GMA activates it. We have, both myself and KT will report. We also have liaisons from the different programs that will report in person. For example, nursing and EMS specifically. And then we have duty officers in emergency preparedness and response. And those duty officers take shifts. They work resource requests. They collect information for the commissioner's briefs and coordinate with the different agencies in the State Operations Center. So for example, if we had a transport issue that required a helicopter, we can go to the Georgia State Patrol, who coordinates all air traffic during a response, and get that support from our state partners to get a helicopter to fly something to an area that is inaccessible otherwise. So for example, we flew what's called a plum case to provide network connectivity to the Lowndes County area down in South Georgia. And we actually put it on an aircraft and we flew it down there, and we used our state partners to do that. We coordinate requests. So that's the coordination of request fulfillment, information sharing across the state. We hold daily status calls. That includes our 18 public health districts, our 14 healthcare coalitions, and we're now including our regional EMS directors on all of those calls. We have them report out across the state. We start with the impacted areas so that everyone can hear what the issues are, how they may be able to support, and can kind of lean forward and have that assistance that they need. Daily situation reports. We push out a lot of weather notifications and make sure that everyone in the state is aware of what's going on in the impacted areas. Next slide. On the district level, they are also lead for ESFA on the district level. They may staff, and this can depend. We have 159 counties with 159 EMAs. They do it 159 different ways. So there are some counties where the district staff may actually support that county, particularly if it's where the main district office is. Support that EOC that local emergency management agency activates, and they will do a similar coordination of request fulfillment. All responses begin locally and end locally. So as it works up through the local county, it's going to come to the district first to see if they can source across their counties for that support that's needed. And if they cannot do it, it will then come up to the state for us to provide the support that's needed. So all of those requests for nurses, epi support, environmental health support, COTS, all go to the district first before they're going to come up to us to source it, to make sure that we're using our resources to the best way possible. And then they'll coordinate information between us and the local county public health. So they fill out situation reports daily that we can pull together and coordinate into one single state source of information. Next slide, please. And then our locals. This is our boots on the ground. These are the people that are actually in the shelters. They're going out and checking to make sure everything is safe, doing surveillance. They're providing the clinical staffing for the shelters, making sure that also helping in the recovery of reopening places and our restaurants. And they will staff local county EMAs as well. So for example, like we're Dr. Rustin in the Chatham County Health Department staffs that emergency operations center themselves. What you'll find is in some of the more rural counties where potentially that EMA is wearing multiple hats, they may not activate a full EOC that's sat in, so the district may help coordinate any resource requests that are coming through that. Next slide, please. So these are not all inclusive, I would say. We always have the odd birds that we get the responses, but primarily through hurricane season, there's things that we have to do. So we are the clinical support in sheltering, so nursing. We provide a lot of the COTS, over-the-counter medications, telecommunications, COVID tests, PPE, all those things. In addition to reaching through like our injury prevention partners to be able to provide us safe sleeping devices if needed, that's requested, all those kinds of things. Environmental health ensures that shelters are safe for people to be in, and epidemiology prevents any diseases from spreading by early detection so that we can provide support. Healthcare facilities for, as I mentioned, evacuations, decompressions, trying to find ways to help them shelter in place so they don't have to evacuate through the provision of additional power, telecommunications, HVAC, and water support. Office of Pharmacy, so assisting with over-the-counter medications, prescriptions. So Policy 14 allows for certain prescriptions to be dispensed for a longer period of time, to fulfill that for longer for evacuees so that they're able to bring their medications with them and make sure they have what they have on hand. It's incredibly important that we get that policy, and the Board of Pharmacy has been great about issuing it each time. We also provide a lot of logistical support. We've become very logistically heavy in this state with the DPH warehouse and our warehouse staff and our ability to support GMA's logisticians. So much more than we ever have been in the past. We're providing a lot of stuff across the state on both the local and the state level. Environmental health I mentioned. So when there's water and there's heat, there are mosquitoes. So vector control, continued facility checks, all of those things. And then EMS services I mentioned with transport and mutual aid for 911 coverage. Next slide, please. So just like I said, there are 159 different counties with 159 different ways of doing it. That would also be true for every hurricane that we respond to. You've seen one hurricane, you've seen one hurricane. They're always a little bit different. We have been very busy this season. So we had Debbie, Helene, and Milton. If you've noticed, the one thing that is the same with the three of them is they were all Gulf hits. So we're seeing a lot of Gulf hits now. The Gulf's been very hot these last couple of seasons, and it's providing a climate to allow for much stronger, larger hurricanes than we have seen in the past. You're going to frequently see comments about, this is the first time we've ever seen this. This is catastrophic. It's never been seen before. So that's pretty much been this entire season in a nutshell. What you will notice is that our state of emergency comes one day before the State Operations Center is activated. We are informed as ESF leads across the state of the impending activation and the state of emergency so that we can go ahead and staff ahead of time for each of these. Each one of them made landfall in Florida. And then when you look at the cone of uncertainty is really what it is. You never quite know where the eye of the hurricane is going to fall in that. So, but what we have been seeing is that it's specifically been South and Southeast Georgia that have been impacted for the most of the season. Next slide, please. So some areas of concern. So Debbie, that was power outages, absolutely. Anytime we get a Gulf Coast hit, we're hitting parts of Georgia that are not built to sustain hurricanes at all. So we see a lot of infrastructure damaged when those types of winds hit those areas. We had a lot of hospital and nursing home evacuations. Debbie, the main issue for us was that kind of cascading event of major flooding. As it moved up across South and Southeast Georgia and moved up the East Coast, because it was flooding the rivers that feed us, we were seeing later river crests that were causing very late in the event evacuations due to the flooding. So a lot of those nursing home evacuations that I just mentioned occurred because of rivers cresting, not because of the initial impact of the storm. Chatham County had to do a lot of initial sheltering, which is atypical for Chatham. Typically they leave, but this is not the kind of event that would have caused that. So they had the challenge of having to shelter in an area, also had flooding. EMS supported a lot of rescues and transports these shelters into our healthcare facilities. And something that we did this year that was incredibly successful is we use contract nursing. So a challenge that comes along with all of this is the fact that we just don't have the capacity for nursing in public health that we did years ago. We all know what the workforce is like in public health, and it's very challenging. So we just recently redoing our contracts to support clinical staffing. This allows our health departments to continue to operate, provide critical clinical services, particularly in our rural areas that don't have good healthcare infrastructure. And so by using the contract nursing, they can stay open. We also use the contract nursing because they're sheltering in the areas that are being impacted. And so the public health staff that are expected to staff these areas live in these areas and have lost their homes or are being flooded or are trying to take care of their family members. So our ability to use these contracts and provide nursing support, and it was very successful from within 48 hours of the initial, yes, you can do an emergency contract. We had nurses on the ground in Savannah. So it alleviated a lot of pressure off of our coastal district and allowed them to take a step back and prioritize their families and their daily responsibilities instead. Next slide, please. Hurricane Helene, catastrophic. Widespread power outages. There was not a single power line still standing in Lowndes County when it went through. They were 100% without power. They said there was 99% without power. We still can't figure out where that 1% came from unless they're referring to the generators. We're not sure. There was no power line standing. Telecommunications, massive issue with cell coverage or any kind of access to anyone. Challenges even finding out if staff were alive and safe after it went through across over a third of our entire state, southern, southeastern, and eastern Georgia. We had hospital nursing home evacuations due to damage, water issues, a lot of decompression to try and reduce the burden on the facility as they continue to try and support the community. Dialysis center closures, health department damages and staff were impacted. One of the benefits of being in the state operations center is that we had the ability to request to be on the flyover list and actually have the state patrol and the drones check our health departments to try and provide damage reports to our locals. A lot of sheltering across multiple districts. So we had coastal, Waycross, Valdosta, Augusta, and Dublin districts all had sheltering across multiple counties. We ended up doing contract nursing with a total of 23 nurses for that response. Next slide, please. And before we even got to begin to think about going home for Helene, we had Hurricane Milton. We luckily were not directly impacted by Milton, and in some respects, the fact that we were already activated made it easier for us to try and support this. So this challenge was the sheltering of Florida evacuees while we were already sheltering for Helene. So the areas that typically would shelter for Florida, like the Valdosas and the Waycrosses, were already sheltering their communities. So we had the challenge of activating in other areas. We had incredible support from our district, emergency preparedness, environmental health, nursing, epidemiology to support the Florida evacuation. And as a Floridian myself originally, hugely thankful for the effort that was made there. So because of this, we had a lot of shelters activated at the same time, 17 at peak, but in total, 29 shelters across the state. We shifted some nurses from Helene as those started to slow down, and some of those shelters were able to pull back on needed staffing and push them to the Milton areas. Again, the other challenge with this, the reverse side of the coin is that when you're trying to shelter an area that is not impacted, you do not want to pull nurses from our health departments because then that impacts our ability to provide critical clinical access. So being able to contract nurses and put them in those shelters ensures that those shelters are being taken care of appropriately. We did not have any Red Cross nurses in any of our shelters. All nursing was provided by public health. And it was either provided by the nursing staff in the health departments or through the contract. It's the only way nursing was able to be provided in the shelters to the Georgians and the Floridians that needed that access. So, but overall, very supportive across the state, just very much a challenge to work 2 hurricanes at the same time. That was a new one. And that's making the season seems to be more and more likely that things like that will happen. Next slide, please. So these are some of the resource requests that we get. Now, some of these will maybe filled at the state level, some of them are filled at the local level. We have a lot of assets in our healthcare coalitions and our district public health offices. We do fund a mass fatality planner in environmental health. He has purchased and that position over the years has purchased and maintained more trailers. And we also have mortuary remain cooling units that we can deploy to ensure that we're able to deal with any mass fatality. But also, if you have power outages, that means you have morgues and coroner's offices that may not have power, may not have the capacity that they need. This enables us to be able to move bodies in a trailer that is self-contained and cools itself. So you can either replace the capacity of a coroner's office or a medical examiner's office morgue that's down, or provide additional more capacity in the event that we have more deaths than a county can handle. And many of these counties are very rural, and they may only be able to handle 2 or 3 bodies at a time. And just with your typical bus accident, that can exceed them. So during an event like this, we had a lot of requests for more trailers. Not used to the extent they could have been. Fatalities were devastating, but not nearly as bad as they could have been. But we did deploy them. We supported with nursing, over-the-counter medications. Naloxone, we ensured that there was Narcan in all of our shelters. When you do have sheltering, you can't have issues with overdoses and drug use and things like that. And while there is security and everything on site, people are going to do things. It's good to have naloxone on site, so we do have that there. Cots and linens. Red Cross doesn't always have cots, and they won't always provide cots in the first 48 hours. In fact, they most likely will not. We have a lot of functional access individuals and people that cannot sleep on a floor. So we, over the years, have purchased a lot of cots between public health and the coalitions, and we deployed a lot of cots and shelter linens to all of the shelters in the state to ensure that we can provide as much comfort and maintain people's health as much as possible through the response. And then we did provide some PPE to one of the shelters that requested it. They wanted some surgical masks in case anybody was sick, so they could try to prevent some disease outbreaks, which I will say was a first for me for an emergency management agency to ask for PPE without us telling them they should. So kudos to that shelter for thinking about the potential for outbreaks and mitigating that. Like I said, border pharmacy policy with pharmaceuticals. We also did the EPAP request this year. So that is active right now. It covers by zip code the individuals that are impacted in Georgia for these under and uninsured individuals to get their prescriptions filled. So that is active right now. And so pharmacies can apply to get reimbursement to provide prescriptions for those that are being impacted in those areas and need that. Healthcare, potable water. Everybody knows that water is incredibly important to all of healthcare. It's what allows us to do things cleanly, safely, and it was definitely a challenge with, particularly in the Augusta area this year, with the amount of damage that was done. It really impacted their water facilities. So, working with Georgia Emergency Management's logistics, getting in tanker trucks, figuring out ways to clean water, getting in pallets of water for them to make sure that, to try and prevent hospitals from having to evacuate. That's really what we want to be able to do. And we were able to do that with support of our partners. Generators, we do own generators across both public health and the healthcare coalitions, and we actually provide generators quite a lot before we work, and then coordinate with GMA for their logistics for their generators. We have a lot of portable HVACs. Along with hurricane season, it is summer. It is very hot in South Georgia, and losing power and air is typically a pretty good reason why, like, for example, a nursing home might have to evacuate. So we purchased a lot of portable HVACs over the years and have pushed those out. Telecommunications with plum cases and satellite this year to try and create some connectivity so people could tell us what was going on and we could actually support them. And then we work very closely with our ESF 12 partners, Power, to do Power Reconnect priorities and make sure they know about the health departments and the healthcare facilities in the area. We provided EpiPens and over-the-counter medications to the linemen this year. There were a lot of wasps and hornets and there's a lot of issues. And then when pharmacies are impacted or you cannot access them because of all of the downed trees, they couldn't get to pharmacies to get basic like calamine lotion and things like that. So we supported that for them this year. And then general support, we provide additional personnel. We deployed district to district healthcare coalition and EP directors from Athens and Columbus to Augusta to support that response. And that was incredibly important to that area to get that kind of support. Next slide, please. We work with a lot of people. We do not do this on our own. So the Department of Community Health, the Georgia Hospital Association, Georgia Healthcare Association, Georgia Pharmacy Association, they put a lot of information out for us and help us get answers. We work with GEMA, Human Services, Red Cross, and the Department of Agriculture and the State Patrol, because you have to shelter pets and you have to provide security. That is the Shelter Task Force. The Georgia Environmental Finance Authority, GEFA, and the Southern Company for our power reconnects. It's been incredible partners over the years. And then with water, a lot of it's well issues and things like that. And so those are our EPD partners, making sure that there's generators getting back on those pumps to get that water moving again. And then working with GEMA, State Patrol, and our Guard and Forestry partners for transportation. Next slide, please. And so that's a lot. It was a very busy season. I'm happy to take any questions that anyone might have that I can try and answer.
Thank you very much for a really comprehensive report, and particularly for the outstanding work you've done under such emergency situations. Are there any comments?
This is an excellent report. Do you think we could get somehow some positive publicity for the Department of Public Health with this extensive work? I mean, do we have any contact who could write a feature article? You really don't hear much about public health and emergency preparedness. You know, you hear about FEMA and GEMA and all that. I think we need us a little feature article.
You know anyone who can do it? Why don't you ask? No, I mean, I have some ideas, Dr. Mercer. Let me call you later. If not today, soon.
This is Michael Walker. I'd just like to commend you on a very detailed report, and it's amazing how much work you guys do in emergency situation. The question I have is, how do you coordinate with FEMA? Because I know that the Federal Emergency Management Association or agency, they try to provide assistance to states. So how does that overlap?
Excellent question. So the way that it works is FEMA is basically the federal version of GEMA, and HHS is the federal version of us. They're ESF8 for the federal government. We provide information into GEMA. It depends on what it is that we need. So for example, if we're running out of generators in the state, regardless if it's because healthcare facilities need it, lots of other people need them too. We could put that request into GEMA that we need generators. If GEMA does not have any more generators, they will then ask the federal government, FEMA, for support, either through assistance from another state. We've gotten generators from New Jersey before. That was during Hurricane Michael years ago. Or they'll try and procure things. FEMA does have a liaison to Georgia that sits in the State Operations Center, and we're able to coordinate very well. But he's an excellent asset. Actually, to Georgia, we're very lucky to have him. But we also have HHS's underneath the Administration for Strategic and Preparedness and Response at ASPR. We have regional emergency coordinators or RECs. So we have them for Region 4. It's the same region of the 8 states that FEMA has, it's the same map. And we go to our RECs to say, I need help with X, Y, and Z. So if we can't help district or local public health, we'll go to basically federal public health and say, we need help getting something. So the EpiPens that we coordinated to distribute through our linemen, through pharmacies and EMS appropriately and safely, I promise everyone. We actually got that through the regional emergency coordinators who then contacted FEMA if they need any help. So it's some lateral movement and then a lot of up and down. I hope that sort of answers the question.
It does. Thank you very much.
Thank you, Leah. Does that conclude our meeting?
And as you're thinking about the next meeting, let us know if there's specific topics that are, foremost on your mind, because we love to be working on issues that are clearly of interest and importance to all of us and what the epidemiology shows us, but would love to be able to further pursue those special issues for you all. I just saw, Dr. Curran, that that COVID was no longer the leading world killer, it's tuberculosis. I think we need to consider how we can spotlight some of the challenges we have in Georgia, because there have been ongoing challenges, as well as some of the really innovative, newly emerged MCH programs, including our home visiting program, which we've talked about a little bit, but I would really hope that coming up we can spotlight those even more.
Well, thank you. We will send our topics in, and this has been an excellent meeting. And I just wanted to point out that Dr. Shin joined us very shortly after roll call, so we had 100% attendance of the board. So thanks to the board as well as to the staff for the excellent meeting.
Dr. Curran?
Yes.
Hey, can I make one quick comment in support of what Dr. Mercer said earlier? Dr. Toomey, I feel that a lot of the work that is done by our various state departments doesn't get to see the light of the day that it should. And in particular, the work that public health officials do every day, including the work you all did with the chemical fire in the Atlanta region. Those types of things require instant and vigorous response. And I do feel that we ought to be out there as much as possible, making sure that people understand that we have their best interest in mind and that we're constantly looking for the best public health approaches to protect their health.
Thank you, Dr. Jane. Do we have a motion to end the meeting?
So moved.
Any second?
Second.
Good. I'm not sure we need one, but we have one now. So we'll see you all. And please send, it gives me something to do. So thanks a lot. We'll see you again.
Bye. Thanks so much.
Hi, guys.
Happy Thanksgiving, everyone.
Yeah, happy holidays.